Hello, everyone. It's good to be with you today, even though I'm not with you. So this is a pre-recorded presentation, and I'd like to thank Professor Sherry Fong for inviting me and for seeing the importance of this topic, for which I'd like to just jump right in. This topic is called Working with LEP Patients and Interpreters, and LEP stands for Limited English Proficient Patients, those who don't speak English very well. And I am my name is Suzanne Zeng, and I'm from the University of Hawaii Center for Interpretation and Translation Studies. I'm retired now, but this is my passion, and I have a lot to say. And so let's just jump right in here. First of all, I just want to start with understanding communication. We all know doctor-patient communication is extremely important. And both healthcare providers and patients agree that one thing that is essential to high quality medical care is effective doctor-patient communication. I think we've all heard people say, oh, I don't know about my doctor, or, oh, I love my doctor. And sometimes it's all about communication and how they communicate. And so I want to talk a little bit about this. What exactly makes good communication? Well, one thing is good communication skills. I'm not sure if you have other classes or other teachers talk about this or you have readings, but I'm sure that you can learn communication skills. It's very crucial when you're dealing with other people and patients. But there are also language barriers to communication, and there's cultural barriers. And those two are what I want to focus on, and how to overcome those barriers when you're dealing with patients who are limited English proficient. So first of all, let me give you a little bit background about the demographics here in Hawaii. There's about 1 in 8 Hawaii residents, which is about 12%, are considered limited English proficient or LEP speakers. That means that they speak English less than, quote unquote, very well. And that's actually according to the law. We have a language access law that was passed here in Hawaii in 2006. There's also federal laws that mandate the use of language access to help people get access to services that any English speaker would get access to if they are limited in their English proficiency. And nationwide, that average is about 1 in 11 people. So in your practice, in your future practice, you definitely will be coming across patients who are limited English if you practice here in America. So I just wanted to point out what happened with COVID when COVID-19 hit. And they started taking, this is from the Department of Health. Let me move my thing. In fact, let me get rid of myself here. Okay. So you can see that they started taking better statistics in around July when they started, asking them, please write down these people's backgrounds, especially in terms of race. So you can see that the number one COVID patients back July, August, all the way through November were Pacific Islanders, and then Filipinos, and then Native Hawaiians, and then just pure white, no mixture of anything. And Japanese were next. And again, there's a lot of statistics that they did not have. But if you look at the next slide, we wonder, what does it mean to be a Pacific Islander? Well, the CDC, according to their race categories, actually lumps Native Hawaiian and Pacific Islanders together. And if you break it apart, you'll see that they're Native Hawaiians, Samoans, Chuukese, Pohnpeian, Coastarian, Yapese, Tongan, Chamorro, and about 19 others, because a lot of these also have their outer island languages. So when they started getting more specific in keeping track of these Pacific Islanders, with the stats that the Department of Health had, we can see that Chuukese was the number one race that got COVID, and Marshallese climbed significantly. as well as Samoan. And then Micronesians that were not specified were next, along with Coast Ryan and other Pacific Islanders, Tongan, Pohnpeian, et cetera, et cetera. So they learned a big lesson throughout this whole pandemic in how to help them prevent from spreading the disease. And they said they learned they needed to provide culturally competent language services to promote effective communication during case investigation and contact tracing process to inform prevention messaging. So when they're calling people at home and they don't speak the language, they're like, oh, okay, we're going to need competent language services that also understand the culture. Because what was happening, let's look at the second one, is that they wanted to understand better the role of the household structure and how large families with limited space face challenges following isolation and quarantine guidance. So what was happening is that in the hospitals where they were getting language services, they would say, okay, you have tested positive for COVID. Now go home and isolate yourself. And they're like, well, what does that mean? Well, that means, don't be around other family members. And they're like, well, how am I going to cook? What about the child that I take care of? And they're like, okay, I guess I'll try. And they go home and they find out later that they're living with 11 people or 12 people in a 2-bedroom home. And that is very, very, very common among the Micronesians because that's how they can afford to survive. And then when the Department of Health realized, wow, they're spreading so quickly, they started investigating, they found out this was an issue. Now, language barriers to communication can be overcome, but we need to understand the level of language. And this is just simple. We put this in 3 simple levels of language: elementary, narrative, and conversational level. So let me explain that. What does that mean? So the elementary fluency is someone who's able to piece together phrases or words, just using simple words, and to respond to basic yes/no questions. For example, where do you live? What is your name? What is your address? Are you married? Things like this. How much money? Oh, $10. It's something simple that they are able to respond simply with. That might be an elementary fluency. Another type of fluency is conversational fluency. Now, is it really fluent? Well, this is the level of fluency. Able to carry on informal conversations using simple sentences and basic vocabulary. So for example, are you married? Yes, married, or are you, simple sentences. But when it comes to complicated things, it's beyond the level. So these are the kinds of the level that can fool a lot of us into thinking that their English fluency is very good. The next level is called narrative, and they're able to fluidly describe events, articulate abstract ideas, express emotions. That's called a narrative level. And usually on a narrative level, if they're LEPs or limited, but yet they're very narrative, then they're probably not as LEP as they're not limited like conversational or elementary level would be. So I'm going to talk a little bit more about these 3 levels and how it affects communication and what we should do about it if we meet somebody who's on a different level. So our language might be conversational, very good, but if it's a second language, these external factors can affect our proficiency. One, for example, and one might be unfamiliar circumstances. So if they walk into the hospital or they go into the jail or, they see a police or whatever, they may be very nervous, or in times of emergencies, or if they're emotionally distraught, like some sick people are, or some people with illnesses, or maybe family members with illnesses. If it's private or sensitive information, or if they get shy or they get embarrassed, it might affect their language ability. And when facing persons of authority, many people just shut down. Or if there's a lot at stake. So I remember meeting a friend of mine who was Chinese, and he was in the, I'm going to show myself a little bit here. He was in the PhD program at UH. And I was interpreting in the courtroom, and I saw him there. And I think he got some kind of ticket that he wanted to argue. But he asked me, hey, can you interpret for me? I'm like, what? You're in the PhD program. Your English is good. He says, no, I have no idea what's going on here. I am so nervous. I feel like I can't even speak in English anymore. So it was really interesting to see how that affected his English ability, English level. There are also cultural barriers to communication. I'll talk a little bit about that. For example, cultural perspectives on health or hygiene, on healing or how you get healed, or even on mental health. I remember meeting one of my own interpreters that I had, that was a student of mine. And I met him at Kaiser and I said, oh, are you here to interpret? And he said, no, I'm here to see a doctor. He says, I'm so excited. I said, you're excited to see a doctor? He says, yeah, this is the first time I have ever had an appointment to see a doctor. I said, first time since when? He said, since ever. I said, what? And he was Chuukese. He said, you know, we just don't see doctors. We just don't. It's not a part of our culture unless we're really, really sick. And then a lot of us will take an airplane or something and fly to Guam or Hawaii or something to see, to go to the hospital, see healthcare if it's really that serious. But he said, I'm really excited. And I'm like, okay, so that tells me they're not used to what a doctor-patient meeting is and what their responsibility is and what their rights are as a patient. So they a lot of them have no clue. They think they can walk into the hospital, and a lot of times they will come in with a lot of people because it's polite to accompany people to the hospital or to the doctor rather than letting them go by themselves in many of these cultures, including the Chuukese culture. So many times you'll see, you know, 5, 6 people coming with somebody to a doctor's visit. And you're like, why are all these people here? Sorry, you guys can't come in. You know, but of course, during COVID, that's a different case or different reasons. But one time, one of the hospital staff asked me, you know, why are they, you know, why do they bring all this food and things like that? And that just told me that there were some cultural differences in their perspective on healthcare and what it means to be to see a doctor and things like that. So that's something to be aware of. It's not wrong, it's just different. And if we're confused, we should just ask about it and understand a little bit better so that we don't create bias on our part. For example, hygiene. I remember one of my my nieces said to me, you know, this is why all these so-and-so type of people are getting sick for COVID. It's because they have bad hygiene. And I thought, where did that come from? Do you ever hang around them? Have you ever lived with them? Have you ever been to their, you know, to their country? Of course, she has not. So it was just some bias that had grown out of maybe seeing somebody in slippers. I'm not sure, but I don't know where that came from. Maybe just thinking that you're sick because your hygiene is bad. You don't know how to wash your hands, etc. So again, different ideas of healing is very important. There's a lot of cultural issues that arise during the healing process, especially when it comes to herbal medicine. And of course, mental health issues. They have different perspectives. I know that in the Japanese world, sometimes even on a job application, they will ask you, have you or your family members ever been to a mental health doctor? And that alone could prevent you from getting a job. So it's taboo to talk about that. They just will not. What is considered taboo? Well, that might be one of the things. And then there's other things that maybe they just don't talk about. It's not good to talk about death, for example, in the Chinese realm. And so it's really hard dealing with cancer patients. Gender issues is another thing. Some have cultural barriers. For example, having there's a Marshallese man that will not take female patients. He will not see female patients or interpret for them. He just feels it's wrong. And others they do, but he just feels it's wrong. So that might be an issue. If it is a gender or sensitive issue with some cultures. When you're asking for like language help, you may want to say, hey, this, I feel like this patient needs a female interpreter, for example. And then also how to treat persons of authority or how you show respect. Do you look at them? There are some cultures that feel looking at them is disrespectful, so they will look down. There are some mothers that carry their babies, and when the doctor's talking, they're just looking at their baby. They're not looking at the doctor, not because they're not listening, but it's because it's disrespectful. So that's something to be aware of. Is it okay to ask questions? Every time you finish, a doctor will say, do you have any questions? And there are some cultures, a Marshallese friend of mine said, they never ask questions because sometimes it seems like if you ask a question, you are doubting their wisdom. You're questioning them by asking a question, and they don't want to question a doctor. So sometimes the interpreter told me that she sometimes will change the way she says that question. Like, do you have any questions? She may say, oh, do you want to know anything more about maybe, and she'll give examples, how to breastfeed your baby or this or that. And then they'll think of oh, I actually do. And then they'll understand what it means by questions. In other words, you want to find out more information rather than, do you have any questions? To question the doctor. And is it okay to make a complaint or to get a second opinion? This is something that's very foreign. It's very disrespectful for some cultures to do. And giving choices. I know one time a Japanese man said to one of my former students, as she was interpreting, why is this doctor asking me what to do? Doesn't he know? Because we like to give choices. This is the risks and this is the benefits, and you have to make the choice. So there could be misunderstandings. Also, another thing is who makes the decisions about a patient's health or about giving birth or surgery. In a lot of the Micronesian nations, they have to bring an elder with them, and so like sometimes the doctor will say, okay, do you want any pain medication before you give birth? And this is what's going to happen. And these are the risks of that. And do you want an epidural, et cetera, et cetera. And then they explain, and the patient says, okay, now talk to my mom or tell that to my aunt, let her make the decision. And they're like, oh, I have to go through this whole thing again. And then they turn and they say, so once you get to know certain cultures, such as Micronesian, sometimes if they're bringing someone in authority, you should bring them into the conversation because it's the elder who's going to make the decision anyway. So sometimes it's the grandparent or the father or the parent. Sometimes in a family meeting, they need a family meeting before they can make decisions. So they do not want to make a decision right there. You'll talk to the patient, and then they'll say, you know what, I can't make this decision. Let me call you back, or let me get back to you about that. And you're like, why? Why can't you decide now? Well, come to find out, they have to go and talk to their family members about it. And they have to have a whole meeting and then allow the elders to make that decision. And then there's cultural medicinal healing sometimes. And so what's important that I want to tell all of you is that we need to recognize abnormal responses as a possible cultural issue rather than, why are they refusing treatment or why are they being stubborn, for example. So we just have to recognize that sometimes it is just cultural. So the cultural proficiency is something very important we have to understand. For example, some people are very unfamiliar with the concept of forms. And in America, we're always filling out forms for everything. Well, guess what? Like in China, if you go somewhere, you have to fill out a form. You don't fill it out, they fill it out for you. So many times it's the person of authority that will help fill out the form. And so if somebody comes up and says, oh, I need this or an MRI, they say, okay, here, fill out the form. Well, first of all, they can't read English. And or if they could, they just don't understand some of the questions. So it'd be best to have the interpreter go over the form with them, or you go over the form with them, and then you fill out the form or the nurse, whoever's supposed to do that. So it's a lot of times they're not used to filling out anything, and they will just leave it blank, and they'll get frustrated, and sometimes they'll leave. We've seen that a lot. Reading and writing skills in the home country may not be that good. Many times they ask us to translate things like into Chuukese or Marshallese or other Pompeian or something, especially the Micronesians. And I use this example a lot because we're here in Hawaii. But a lot of them don't read. They just don't read in Chuukese. So I remember what we did in Straub for actually Hawaii Pacific Health. They had us translate and record a video in Chuukese of what to do if you get COVID. And they played it in the room of the patients. For example, how to, turn over and lay on your stomach. And I forgot what that's called, but, and, how to do this and what to tell your family members and things like that, because it would be easier for them to watch the video and learn than it is for them to read something that they're just not used to reading, even though it's in their own language, because those are oral languages. Also, they have different priorities. For example, education versus family. Family always comes first. If I have to go to the hospital or if I have to go see the doctor, or I have to go somewhere today, maybe I'll take my child out of school just to drive me there. Also, a different idea of time and deadlines. If they're running late, I ask sometimes, even our interpreters do this, or they used to do this. They're running late. I'm like, why didn't you call? They say, well, I didn't want to be disrespectful. I said, but you're going to be late anyway. Yeah, but it's disrespectful to call and let you know that. I'm like, okay. I thought that was very interesting. Also, I said, oh, what are you going to name your baby? Oh, I don't know. I'm going to wait till after he's born. Oh, why? Oh, I don't know. We just don't, we don't even have a word for schedule in our language. I said, you don't have the word for schedule in your language? Yeah, we don't. So you'll notice that when you're telling people to come back on, next month on a Friday, such and such a date, they're not even writing it down. So you may notice that and want to write it down for them. And especially if it's something like, oh, I want you to take 2 of these every day, and then I want you to take 3 of these, or this once a day, it might be a good idea to write that down and then have the interpreter, write it in their language and hand it to them. Because they're not, some cultures are just not used to having even a schedule. We also want to watch for signs of language or cultural barriers. Sometimes you won't notice it because they're answering your yes, no questions, and it seems like they're understanding. But in their mind, they're like, I have no idea what you're talking about. And they're looking at you as if they're intent, but they're like, what are you saying? And they're trying their best. So we have to look for signs that there are barriers. One sign is the patient's nodding their head. Doesn't mean that they fully understand. We know the Japanese will nod their head, even they're like, I don't agree at all what you're saying, but I hear you. And others will just nod their head because we're nodding our head. Do you understand? And they're just copying, mimicking. Also, they often respond with a yes or no or okay. So when a patient responds with yes, no, yes, no, it doesn't mean they really understand. One time I was in the court, and I do a lot of court interpreting as well. And and the judge was saying, okay, you've been charged with this. So I have to ask you some questions. Are you guilty or not guilty? I did it. They didn't answer correctly. They said, yeah, yes. Did you do this? It's like a driving. Yes. And they answered yes. So the judge took that as they were admitting that they, sped or whatever it was. They said, okay, so you're giving up your right to a trial. Do you understand that? Yes. So do you understand that you're giving up your right with 12 people to be a juror, and they have to listen to the evidence, and if they don't listen to if they hear the evidence and they find you not guilty, then you won't be guilty. Do you understand that? And he goes, yes. And then he says, and then he says, have you been drinking in the last 48 hours? And the guy says, yes. And he was not understanding anything. He just answered yes, no, yes. And he just thought yes. And then when everyone started laughing at that answer, because there were people in the audience, in the courtroom, he just, no. And he just changed it quickly. So it's very dangerous to just ask yes, no questions. Also 1 or 2 word answers when they should be giving a long sentence and they're only answering with 1 or 2 words. It's something you have to pay attention to. Maybe they didn't fully understand. And they never ask any questions. Maybe they didn't understand. or maybe they don't want to ask a question, or if their response is odd. And that's something you may want to. So you may want to think, okay, something was not right with that response, and you may want to ask again. Or if they're uncooperative or indifferent, if they're just not cooperating, it might just be a sign that they just don't understand, or there's something culturally going on. So you want to find out. They may be evasive. They don't want to answer the question. And that might just be because they didn't really understand, or that they're indecisive. And again, like I said, maybe you're asking them, do you want this? Do you want that? And there might be something cultural going on. Like they want to talk to their parents and they don't know if they're allowed to leave or if they're allowed to, or they want to talk to their family members. And so that may be something. Did you want some time? Is there something, did you want to talk to your family, or is there a reason why you don't want to make a decision yet? And they may be able to tell you. Also, if they look frustrated or upset, that might be because they're embarrassed because of their language, or it might be a cultural issue. So you want to dig deeper. Ineffective communication can result in misdiagnosis because they're not telling you everything. Inappropriate treatment because they're just not telling you everything. Medication errors because they're saying, oh, yes, 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 yes. Did you take your medicine? Yes, yes, yes. And they didn't even understand what you said. And actually, they're not taking their medication, maybe. So that can be very, very dangerous. Difficulty in following discharge instructions. I've interpreted for especially the nurses that come in and they're in such a hurry. Okay, you have to take 3 of these every day, and you make sure you take it with food. And this one you have to take it in the morning. And then I want you to go off. And when you get home, by the way, before you get home, you got to stop off and get the medication first. And I put it at the lungs, it's near your house. And they talk so quickly. And even I can interpret that it's too much information for a patient who is unfamiliar with American, how it works here. If they're unfamiliar with it, culturally speaking, it's just a lot of information. And they're just going to say, okay, 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 thank you. And they leave not knowing, really not knowing how to take medication, et cetera, because they didn't write it down. Then you think, well, that's okay. The pharmacy person will explain it to them. Well, guess what? They show up at the pharmacy and they can't speak English very well. And then the pharmacy says the same thing, explains all this, and they have no idea. And they're not writing anything down. And that is, if you notice they're not writing it down, that's when you should probably pick up a pen and write it down for them and hand them that piece of paper. And it's okay to write the English name because the bottles will have the name of the drug on it. So you can always write the English name and say 1x, per day or something like that. And that would be a lot easier for them to follow your discharge instructions. Now, I don't know what this, okay. So how do we bridge the gap between culture, language, and communication? So there is sometimes a gap between our communication. And some strategies which are very ineffective are speaking louder, asking the patient if he speaks English, and they say yes. Asking the patient, do you understand? They say yes, because you don't know really if they understand. And of course, speaking louder is ineffective. Speaking slower doesn't help because they still don't understand the words sometimes. Another one is repeating one's words, repeating it enough times, thinking that they actually understand when they don't. Or using gestures. Okay, you got it. Okay, so these are all ineffective, very ineffective strategies. So the good way to bridge the gap is using language services, someone who is culturally and linguistically aware of the issues, of the communication issues. And you will find if you use a really good interpreter, it's just like speaking English. I guarantee it. All right. Where do you get an interpreter? Well, another word for interpreter, let me move this, is oral translator. But we don't call them oral translators, we call them interpreters. Now, a translator is someone who translates written documents. So if you say, I need a translator, to me, I would say, oh, you have a document you want translated? when actually you might mean interpreter. So now I think most people know an interpreter means an oral translator. That means you need somebody to listen and to interpret. So that's an oral, that's an interpreter. All right, now people come with family and friends. So that's one place you can find an interpreter. Another one is bilingual staff. Another one is a professional agency. And they can usually do face-to-face interpreting or over the phone or over video, which we call video remote. Sometimes you'll hear a VRI, video remote interpreting. Okay, I'm going to move myself up there. All right, finding an interpreter. Now, if we use a family or friend, the good thing about it is that it's quick, very convenient, because they come along with the person and then we just use them. Or you start talking to the patient and their husband starts answering the questions and you think that the patient understands when actually the patient's clueless. And then the husband understands or the patient's clueless because they're not interpreting. They're just talking. So that is one of the biggest dangers that I find in healthcare today is unknowingly the doctor talks to the patient and then the husband or the spouse answers or the child. And then we start talking to them, assuming the patient understands. So it's very dangerous to use family and friends because guess what? They don't interpret. Sometimes they do, but for the most part, they don't. They just answer the questions. The bad part is they lack vocabulary sometimes. They don't have the vocabulary. They don't know the technical terminology. They may not fully understand. So they might fake it and not admit that they don't understand. If you explain something and you say, oh, could you please tell the patient, they may not fully understand and they won't tell you that. They'll just kind of fake it. Oh, the doctor says you need some kind of operation. It's on your stomach. And they just don't understand it themselves. They may answer questions without interpreting. That happens a lot. Also, they may speak much longer than what you spoke. They may speak much shorter than your original utterance. And you know that they're not being accurate. The medical staff might think that what they said was fully understood by the patient, like discharge instructions. Yeah, you got to do this, got to do this, when actually it may not have been interpreted fully. So what is the difference between using a bilingual person, such as a family or friend, and an interpreter? Let's talk about that. So bilinguals, they're usually fluent in 2 or 1.5 languages, meaning actually they're monolinguals. They may not be that fluent in English, but they might be, not sure. But they might or might not know medical terms in 1 or both languages. And they often add or omit information. And that's what I kind of said in the previous slide. Now, an interpreter is fluent in both languages. They have been tested or they have been, they should have been tested and they're fluent in both languages. They should know medical terms in both languages. And you'll notice many times a professional interpreter will bring a glossary with them, either on their phone or a written glossary, because they prepare for their interpreting assignments, or they have studied and they already know the medical terminology. They interpret accurately. They shouldn't add, they should not omit any information, anything. They should know the skills of interpreting, such as note-taking techniques. So if you go on and on and on, they should be able to write. So you should always see an interpreter with a notepad and a pen. And if they don't bring one, then they're just either being lazy or they really don't know the techniques of note-taking. They should know the role of the interpreter. They shouldn't be adding information or giving advice or making suggestions to the patient or to you. And they should know the code of ethics. And we'll be talking about that. So effective communication through a competent interpreter. I want to talk about that. Effective communication through a competent interpreter. Well, what is a competent interpreter? It's someone who has skills. Now, this means language skills, which I just said. Also skills of interpreting. That means maybe they've taken classes, or maybe be it online or at the university, they've taken classes and they know the skills of note-taking and concentration skills, etc. And then ethics, I'm going to talk about that, and background knowledge. So the first thing is skills. There's three modes of interpreting. One is simultaneous interpretation. And we use this mode when, for example, let's say I'm an interpreter and the husband and wife are there, and all of a sudden they start talking in their language. Well, as a trained interpreter, I will simultaneously whisper to the doctor everything that they're saying. For example, the husband's, you need the surgery, and without the surgery, I'm not sure, it could grow, da, da, da. And then the wife goes, get the surgery. And then the husband goes, I don't want the surgery. It might, we don't have the money for the surgery. Now, as an interpreter, if I start interpreting that to the doctor, we don't have the money for interpreter for the surgery. Then the doctor can say, excuse me, I think your insurance covers this, so that's not going to be a problem. And then the doctor can interrupt and say whatever they need to, he or she wants to say. And at least they can fully understand what the problem is and why the hesitation, because the interpreter is doing their job. Now, if the patient says something to the interpreter, hey, interpreter, what do you think? Should I get the surgery? I, as an interpreter, trained interpreter, I will use the next mode, consecutive. And that's the back and the forth and the back and the forth. And, I pause, wait till they say something, I pause, and then I interpret. And then the other person says something, pauses, and then I interpret it. That's called consecutive. That's the most common mode. But if they say to me, hey, interpreter, should I get the surgery? What do you think? You've been in America a long time. Then I will turn and say to the doctor, hey, interpreter, what do you think? Should I get this in surgery? And I'll just interpret it. And then the doctor can say, wait a minute, don't ask the interpreter. You have to make this decision. So those skills come in handy because I know what I'm supposed to do and I know the role of the interpreter. I also know skills. Now, the next one is called sight translation. And that is when there's a written document, for example, a consent form, and the interpreter needs to read it to the patient in a different language. So that can be extremely challenging. For example, this one, consent for crisis counseling. I consent for the provision of crisis counseling services by the SATC as needed for me and or my, these services. This is very, very difficult because it's a lot of dense information in written form. Very, very difficult. It's easier for us to have the doctors read it or the nurse read it and for us to interpret it through our ears because we filter certain bits of information like the grammar, whereas reading is very challenging. The next thing, the competent interpreter not only skills, but ethics. They know the role of the interpreter. They know the do's and the don'ts of the interpreter. What is the interpreter's role? Well, it's to facilitate direct communication between the provider and the LEP individual. That's all I'm doing. I'm helping the provider speak directly to the LEP as if I was not there. But all I'm doing is interpreting the words. You can say, I'm like a voiceover. Therefore, the provider says to the LEP, how are you today? And I'm going to interpret, how are you today? He says, oh, my stomach hurts. I'm going to interpret it. Oh, my stomach hurts. I'm sure the doctor's not going to say, what, interpreter? Your stomach hurts too? It's not going to happen. So if we are fast in what we do, it helps the provider and LEP have direct communication, and that helps break down the barriers. What is the correct positioning? Well, for example, this is position 1, and the interpreter is like wearing a suit, looks very professional, but he is the center of the focus of communication, and this is absolutely incorrect. Position 2 is correct. The interpreter is in the background. He's just a voice, and it's the doctor or the nurse and the patient having direct communication. That's what we want. So the interpreter should stand out of the way. And then we know our code of ethics, and that's a handout that I gave. And it talks about the 5 major code of ethics that we put together. There's a lot out there, but we put together under these 5 categories: accuracy, confidentiality, the HIPAA laws, for example, impartiality, neutrality. I'm not going to take the side of the patient or the side. I'm not going to take sides. I'm just going to remain neutral. If they say, interpreter, what do you think? Should I have the surgery? I will turn and just interpret it. Interpreter, what do you think? Should I have the surgery? I'm not there to give advice or to take sides. Role boundaries, I'm not there to give advice. Like I said, I am just the interpreter. They want me to be the doctor's assistant. I'm sorry, I'm not. Want me to give you a ride home? I'm sorry, that is not my role. Professionalism, I should show up on time, wearing what I should be wearing, very professional. And if I have a question, I say, excuse me, doctor, the interpreter needs to clarify a term that you just said. And we act professionally. It helps with all the smooth. The only code I want to go through is the accuracy, so you can fully understand what we're bound by. One is the interpreters will convey the message and the tone of the speakers accurately, completely No adding, no deleting. And that the tone as well. If they're upset, it should come across in my interpreting. Interpreters shall accurately interpret obscenities and sexual terminology and shall maintain composure while interpreting in emotionally charged situations. Now, if you get a family member, there are some things like some sexual term they consider sexual terminology. We may say it's just a body part, but they may not say exactly what it is that is being said. But interpreters are supposed to do that. Interpreters will seek clarification when needed because we need to be accurate. If I don't understand, I'm going to admit it. I'm going to say, excuse me, doctor, the interpreter's unfamiliar with that term. And hopefully you're happy about that because they're not faking it. A lot of non-trained interpreters will fake it. I wanted to show you the use of interpreters on the island. This one is from, this graph is from one language agency of all of January of this past year, 2020. You can see the number one here in Hawaii, number one requested language was Chuukese. But if you put Cantonese and Mandarin together, it's about almost up there. And then we have Korean, Japanese, Vietnamese. We have Marshallese, Ilocano, Spanish, Tagalog, blah, 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 and a lot more other languages. This is just in 1 month. So we have a lot of different varieties of languages here. And it would be different depending on where you live. And like, for example, on the Big Island or Maui, you would have a lot more Spanish speakers. Okay, really quickly, practical aspects of working with LEP patients and interpreters. And I handed out a handout to you. But before we get to the handout, you need to assess the need for an interpreter. Does he really need an interpreter? The goal is to ensure patients are able to express themselves as they would in their native language. That's our goal. So we have to assess the client's need. What level of English proficiency is needed by the doctor? What do I need of them? And what level do they have? If I need them to tell me what happened, narrate it to me, and they only have a conversational level, they're going to be stuck. They may want to say, he shoved me to the ground, and they end up using the word push. He pushed me, pushed down. He pushed me down. And that doesn't sound like he shoved me. It's because their English isn't, they don't have enough words to express what really happened. So this is very important, depending on what you need. If you only need them to tell your name, like an ER, sometimes you only need the name, you only need the the address and things like that. Maybe when they're checking in, then maybe you don't need an interpreter at that level, at that point. All right, so what is their level? Is it elementary? They just give basic information? Is it conversational? Can they understand and speak simple sentences? Can they understand what you are saying? And narrative, can they describe and explain back the procedure? For example, if the doctor just explained the procedure and the risks, how do you know they really understood you? Well, maybe you can say, hey, could you tell me what I just said? What are the risks of this? Do you remember? What kind of procedure are you having? And have them be able to tell you back. If they cannot, maybe you should get an interpreter. Okay, so getting a professional interpreter, easy. Language service providers, they're everywhere. By law, every medical institution must have a language access plan. So if you start working somewhere, you can ask them, how do we get interpreters? They should be able to tell you, because every medical institution, at least a large institution, has a language access plan according to federal law and to JAPCO. Now, some ask staff to schedule an interpreter. Hey, so-and-so, could you please get an interpreter for next Tuesday, or schedule this patient for the next visit and make sure you get an interpreter for them. And they'll call and schedule an interpreter to come. Some train the doctor to call for the interpreter. And I'm going to tell you a secret. Capilani likes to do this, especially if you're working in the Carter unit or the Wilcox, or you're doing residencies there. They get the residents to call. And we have gotten many calls, even from doctors themselves. I need an interpreter. Sometimes it's right now, or it's to schedule an interpreter. And so they're really good at doing that. And it's easy. Once you know the phone number, it's not hard. Another one is telephone and video remote interpreting, and that's available for immediate need. So for example, in the ER, you're probably going to need a telephone or a video remote interpreter. But you'll find that once you start working with interpreters, that it seems a lot easier to work with face-to-face interpreters, just because it is. It's easier because they can just really quickly, you can get up, you can go here and go there. Telephone, it's hard to see what's happening and it's very confusing. And there's a lot of technical issues with the telephone and video. Sometimes you don't have access to the internet goes down, but with a telephone, sometimes they're static or it's so far away. And the interpreter says, I'm sorry, doctor, I just can't hear you. And so you got to get closer to, the telephone. And so it can be very frustrating, and face-to-face is so much easier. But it can't be immediate. Another is with local agencies, you can request a specific interpreter that you like to work with. And you will like certain interpreters. You'll say, oh, I like this one. And so can I have her or can I have him? And you can do that with local agencies or if they work in your hospital. Now, this is a handout that I sent along with this, is working effective with an interpreter. I really will hope that you go through all of this to learn practical ways of working with the interpreter. I just want to point out a few. One, speak directly to the patient, not to the interpreter, to avoid confusion. For example, I'd like to get x-rays of your arm, rather than, please tell him that I'd like him to get x-rays. It's very confusing. So it's especially when the interpreter interprets back, oh, he said that he will take him to get x-rays. What? There's two he's. Who is the he? Who is the second he? It's very, very confusing. So please just speak directly to the patient. If the interpreter is confused, like on the phone, you just tell them, I'm going to be speaking directly to the patient. Please interpret what I'm saying exactly how I say it. Because there's some interpreters who are very new and they need training. Use short sentences and pause frequently so that they can remember everything you said. Some are not good at note taking. So allow them to just quickly get out the information accurately, completely, and ask only one question at a time, because multiple questions is hard on an interpreter's brain and memory. Okay, ask the patient to repeat key information. Check for understanding. Do you understand? No, that's wrong. You should say, can you tell me what you need to do before our next visit or before our next meeting, and see if they can. All right, so please refer to that quick reference guide that I handed out and for more practical tips on working with LEP patients and interpreters. There's a lot of good tips there. And if you have any questions, well, first of all, thank you. Thank you for hearing my passion about using interpreters. If you have any questions, you can ask now. Okay, I'm joking. If you have any questions, you're going to have to contact me. But the first thing is the true false questions. Hopefully all of you did it and you know all of the answers. There may be one question that you may not know the answer. Is there a national exam interpreters can take? The answer is yes, but only in about 5 languages. And it's very recent. There are actually 2 organizations that are national organizations, and they can test an interpreter's interpreting ability and medical background. So there's a written exam on medical background and there's oral. And in Hawaii, we have about 6 people who have passed the test. And again, only in 5 or 6 languages. We have 1 Vietnamese, we have 2 Cantonese, we have 2 Mandarin, we also have Russian, and we have Spanish, a couple in Spanish. So we're very lucky. Most of them are with 1 local agency here, but we're very, very lucky. So if you have any questions, most of the answers on that test are false, but there might be 1 true. So if you have any questions, you're going to have to email me and say, hey, I really don't know the answer to this, but I think we've covered almost everything. So sorry for the background noise here, but the resources are here in the PowerPoint. You can go look at those or read those. There's a really good book there that is actually required reading by Yale School of Medicine. And it's really great about understanding differences in culture. And there's my contact information. So I want to say thank you very much. I can't believe I did this all in 50 minutes. And there's a lot that I cut. So there's a lot more to learn. And if you want to, there's a website that I belong to. I actually belong to Language Services Hawaii. Our CITS website, our Center for Interpretation website is down as they're finding a new director for the Center for Interpretation and Translation Studies at UH. But you're welcome to call me or email me with any information. So again, thank you. Good luck in your future career and good luck with working with LEPs. And I'm so happy that Professor Sherry Fong considers this topic important enough for you to learn. So good luck. And if you have anything to share with me, any kind of feedback, please write it on the feedback form or just email me. And good luck, everybody. And auf Wiedersehen.